So thank you, Dr. Iman.
Thank you.
And now let's give the floor to the second speakers, Dr. Sultan Muteri.
Man, if you can stop sharing, please.
Okay, Doctora, if you don't mind, please.
Only post sharing, or so I did post sharing. Stop sharing. Yes, there you go.
Okay, thank you, Dr. Iman. Now let's give the floor to the second speaker, Dr. Sultan Al-Mutairi. Dr. Sultan is a consultant adult hematology at National Guard Hospital in Jeddah, and he will be addressing the update in thalassemia management. Again, for the audience, please type your question in the chat box so that we can answer it at the discussion time. Dr. Sultan, the audience and I are ready to enjoy your presentation. Floor is yours.
I'm trying to share, but
Do your best.
it is not showing. معلش بس صبر شوي علي بس.
خذ راحتك. معك ساعة يا دكتور علي.
ان شاء الله اكلمك كذا.
إذا حاب التكنيكال سبورت الأخوان معنا.
لا اتوقع اوكي تمام.
اوكي جود.
السلايدز واضحه صح؟
واضح جميل. جو اهيد دكتور.
بسم الله الرحمن الرحيم والصلاه والسلام على رسول الله. شكرا لك وشكرا ل thank you for BMS for inviting me, and also thank you for those who attendees of this our live session. In the next 30 minutes, we'll go over updates in thalassemia management, focusing mainly on non-transfusions lines of management, basically. We'll just touch base on the molecular understanding and clinical forms of beta thalassemia. So one of the key pathophysiology of beta thalassemia is the imbalance between the alpha and beta globin chain, which contribute to all the complications. This is as a result of inheritance of homozygous or compound heterozygous of beta globin gene mutations, or heterozygous hemoglobin beta gene mutations with combined with alpha globin duplications rather than deletions. Eventually, we end up with two issues, which is ineffective erythropoiesis, and this is in the bone marrow, leading to death of erythroblast, usually at the stage of basophilic erythroblast. And those who survive it and go into circulation, usually alpha chain will be deposited in the cells, leading to hemolysis. And the outcome is chronic severe anemia that led to certain set of complications that Dr. Iman already addressed in her presentations. We know there are some modifiers of severity. If there is beta plus or beta plus plus, meaning there is some production of normal hemoglobin, co-inheritance of alpha thalassemia, this balance the alpha beta globin chain ratio, may lead to lesser severity of the disease, or the usual player, which is hemoglobin F, whether in each disease, if it's high, trying to compensate for other defects and leading to milder form of beta thalassemia. So the conventional beta thalassemia phenotypes are usually defined based on clinical grounds with genotype association. As you see, we have a spectrum of beta thalassemia silent carrier, where the patients usually non-anemic and asymptomatic clinically, to beta thalassemia trait, microcytic hypochromic, and this is patients who have been treated for iron deficiency anemia and they will show no response, or they are showing our clinic for premarital counseling or preconceptional counseling. And a group of beta thalassemia intermedia or hemoglobin E beta thalassemia, which usually mostly they behave like thalassemia intermedia. They require transfusion later in life, more after 2 years. They still require transfusion once a while, and they produce some clinical symptoms that might necessitate to be a regular transfusion down the road. And the end of the spectrum, which is beta thalassemia major or severe form of hemoglobin E beta thalassemia, less than 2 years, their requirements of, they start to require transfusion, and eventually it is a patient will die if they are not on transfusion. So as Dr. Iman, I think she touched in her talk, that is, we are moving to use terminology of transfusion-dependent versus non-transfusion-dependent thalassemia, which is kind of more practical point of view. And the term non-transfusion-dependent thalassemia, it incorporates three important diagnoses: the beta thalassemia intermedia, the hemoglobin E beta thalassemia, or hemoglobin H disease, especially the deletional form of hemoglobin H disease. So you have patients who very rarely requiring transfusions, patients who are intermittently requiring transfusions in special scenarios, or they have complication of extramedullary hematopoiesis, they may require transfusion more frequently, or the other spectrum, which is transfusion-dependent beta thalassemia. And we have also under the category of transfusion-dependent beta thalassemia major, and this is represent the vast majority of our patients. And we see other variants, which is uncommon, like the severe form of hemoglobin E beta thalassemia, hemoglobin bars or head robes. This is, I mean, these cases that it detected antenatally and being exposed to intrauterine transfusion to survive. And I will add the non-deletional hemoglobin H, like Constant Spring, they tend to have more severe hemolysis, and they mostly transfusion dependent form. So what the novel therapies that we recently are being currently considered for beta thalassemia? So we know one of the important issues is ineffective erythropoiesis. There is a rest in the late stage of erythropoiesis at the level of basophilic erythroblast. So we need some agents that help with maturation of this stage and allow differentiation. So a number of trials going on different aspects, like erythroid maturation agent, like Luspatercept, which we'll talk about it later, and similar drugs called Thalassemia, pyruvate kinase receptors activators, metabivat, and this and recently in last ASH phase 2 studies was published that show some benefit. JAK2 inhibitors, as we know, there is the JAK, the STAT signaling pathways defect. So ruxolitinib have been studied, and GLYT1 inhibitors, bitopertin, or looking about the hepcidin dysregulation. So they tend to have low hepcidin levels in patients with thalassemia. So any hepcidin mimetics, stimulators hepcidin production, or ferroportin inhibitors in an indirect way to stimulate hepcidin. So all these are considered, are currently considered, have been tested eventually. The other going into the high hierarchy, why going to the defective gene, either gene editing or insertion of a new healthy beta gene, or forgetting about the beta chain gene and going targeting hemoglobin F. Trying, instead of like percentage of 2%, 3%, going to like approaching 60, 70% of hemoglobin F to replace the deficient adult hemoglobin. Gene therapy, now it is one curative option available for patients with beta thalassemia, and recently caught the attention with multiple publications about gene therapy. And its principle, upon isolation of hematopoietic stem cells and progenitor cells, these exogenous beta globin genes are then incorporated into the host cell genome using lentiviral vector. And whether they're getting myeloablative or non-myeloablative chemotherapy, these genetically modified autologous stem cells are retained or reinfused into the patient later. And to be successful, really, the engraftment and gene transfer should really occur at high efficiency, leading to high levels of gene expression. It is similar in a way to autologous stem cell transplant, except you're taking the product, you do the modifications, which is different approaches. We'll talk about some of it later, then reinfuse it into the patient. So there are a number of looking into gene insertion. That means like you have absent beta chain, you insert a healthy beta chain into the gene. And this is all, as I mentioned, is curative intent. So there is BT gene auto Temcel and the Globe and TNS. And this is trials designed like phase 1 to phase 3 trials. And usually the efficacy measures are transfusion independence ongoing trials. These are the ones that are published, hemoglobin 204 and 205 trials, and this is using the product of, as I mentioned, Autotemcel. It is 22 transfusion-dependent patients between age of 12 and 35. 12 of the 13 patients really had non-beta 0, beta 0 genotype, and they have stopped receiving blood transfusion. With levels of hemoglobin ranging from 8.2 to 13.7. And we know with transfusion-dependent thalassemia, usually their hemoglobin is way below 7 or below 6 if they are not transfused. And 9 patients with beta 0 genotype, which is one of the commonest genotype that we see here in the kingdom, the median annualized transfusion volume reduced by 73%, which is really acceptable number, even if they did not lead to transfusion independence. However, I think 3 patients also led to transfusion independence, and I think it's variable between patients. Some patients requiring like 4 transfusion units on a monthly basis, some like requiring 2 transfusions a month, and you expect these two units might be discontinued, while 4 units you can probably reduce to 1 or 2 units per month. And the treatment-related adverse events were typical for those associated with autologous stem cell transplant. One catch happened with Autotemcel. As I mentioned, June 19, 2019, there was conditional approval in Europe for transfusion-dependent beta thalassemia patients who are 12 years old and non-beta 0, and who are transplant eligible but didn't have matched sibling donor. In February 21, there was temporary suspension of clinical trials of this product following 2 reports of AML and MDS in sickle cell patients with probably with the same product. However, this hold was lifted by FDA as the cases were not attributed to the gene therapy, but there was some issue with reimbursement challenges, not due to safety of the medication, that led to its withdrawal from Europe. So this diagram is showing what the aspects of targeted areas of new therapies. As I mentioned here, there is alpha and beta chain imbalance. So with excess alpha chain, so reduction of alpha chain might help, and this is one of the targeted mechanisms. The impaired beta globin gene, either with bone marrow transplant, you replace and insert healthy new bone marrow, or gene therapy, you are modifying the beta chain or repair it or insert a new one, or going with hemoglobin F induction. And then I mentioned the pyruvate kinase receptor activation, trying to reduce the hemolysis, which is part of the pathophysiology of thalassemia, or targeting more hepcidins, like many hepcidin analogs or TMPRSS inhibitors, and other drugs targeting ineffective erythropoiesis like JAK2 inhibitors and Luspatercept. So there is a number of hemoglobin F induction trials, and it has really positive results. So as you see in this graph, which is morbidity score versus fetal hemoglobin level. So as the fetal hemoglobin level go up, the morbidity scores goes down, and this is kind of more marked with hemoglobin F than other parameters. The trial or the studies looking into targeting hemoglobin F, even in the 90s and 80s, were an area of research, but it did not really pan to be an effective eventually. So there are number of drugs. They try some chemotherapeutic agents like azacitidine and decitabine, with a goal. All of these goals are just to increase hemoglobin F, which seemed there may be some improvement. However, there are significant limitations, either the sampling size, the magnitude of effective increase hemoglobin F was like slim, if you take it in contrast to the toxicity of this medication. Hydroxyurea, it did work beautiful in sickle cell disease. There may be some, I would say some mild effects seen with non-transfusion thalassemia, but eventually the magnitude of its effect was lacking on the long-term response. So we don't use it with patients with thalassemia. Other agents have been tried, like short-chain fatty acids, did not show to be effective in long-term. Erythropoiesis stimulating agents. I mean, we know that erythropoietin is normal or maybe high in patients, it's high in patients with beta thalassemia. Trying to use this erythropoietin agents like as we use renal patient to increase hemoglobin F did not pan to be effective, unlike normal patients. Thalidomide also with the principle of increasing hemoglobin F, but it was really toxic medication. So none of these are used in standard practice for patients with thalassemia. Gene editing. So what the main thing is about targeting BCL11A. BCL11A, it's a main regulator of hemoglobin F, and it's been area of interest for researchers. So these, it's involved in suppression of hemoglobin F, and the gene editing using specific nucleases. It might be possible to delete by genome editing the BCL11 or its specific promoter, prevent its expression in hematopoietic stem cells or only in erythroid cells, leading to increased production of hemoglobin F in these cells. So this is one of the targets of gene therapy, not just repair or add new healthy beta changes, to target hemoglobin F with different modalities to increase its levels. And there are certain engineered nucleases like ZFN, TALEN, or CRISPR-Cas9 that being studied. So, this is kind of two gene editing clinical trials, product CTX001 or ST400, that looking into a phase 1, phase 2 trial with a key efficacy measure is transfusion reduction as an outcome. So the first one, is published as Climb-Thal 111, first in human CRISPR-Cas9 clinical trial and thalassemia using the product CTX001. So around 10 patients, this is interim result published, 4 out of 10, they had beta 0 or the common mutation that we observe, which is IVS1 110 mutations, follow-up of around 9.8 months. Patients really achieved engraftments of neutrophils and platelets at median of 30 and 38 days, and all demonstrated increase in total hemoglobin F, and F cell pancellularity. And this is pancellularity, it means there is pancellularity and there is heterocellularity, it means distribution of hemoglobin F in the F cells basically over time, and the pancellularity, which is what we need. So the mean total hemoglobin at baseline 10.6, including 0.2 gram hemoglobin F, and mean total hemoglobin at 21 months reached up to 13.3, and increasing of hemoglobin F up to 12 gram per deciliter. So patients also stopped transfusion within 2 months after the product infusion and were transfusion free up to 23 months. The safety profile, as with other gene therapy, is just the main downside of gene therapy is the conditioning chemotherapy. The hemoglobin and F inducing agent trials. So there is IMR 687, which is a potent, specific, highly selective molecule inhibitor of phosphodiesterase. It mediates the cellular signaling pathways by degrading cGMP to its inactive form, and by inhibiting phosphodiesterase, it increases cyclic GMP levels, stimulate hemoglobin F production, and this is being seen in the preclinical models of patients with sickle cell disease. And it's like a phase 2 randomized trial with key efficacy measure ongoing for transfusion reduction by 20 or 33% reduction. The benzorazide, it's also decarboxylase inhibitor used in patients with Parkinson. However, it's shown that in some studies that increase hemoglobin F and erythroid progenitors, like in transgenic mice and anemic baboons, so it's under investigation. The other aspects, as I mentioned, the alpha chain reduction pathway. So as I mentioned earlier, the alpha chain, when it's in excess, it's either deposited red cells leading to hemolysis, also with activation of apoptotic pathways leading to ineffective erythroid. So in different ways, it's really bad for patients with thalassemia, excess-free alpha chain. So trying to reduce alpha chain might restore the balance to a point that ameliorate the severity of the disease to a certain extent. So as I mentioned, clinical genetic data reported during the last 30 years have provided increasingly strong evidence that reduction of alpha globin expression by 25 to 50 will ameliorate the clinical severity of many patients with beta thalassemia. And animal studies with use of CRISPR Cas9, genomic editing, xenograph assays show the proportion of these 34 cells are long-term repopulating hematopoietic stem cells, the potential of this approach to translate into therapy for beta thalassemia. And this is just number of papers that will establish probably basis or foundation for further research on that aspect. Now we'll talk about some regulation of erythropoiesis, and we'll touch just shortly on it. It's a complex network with a transcription factor, epigenetic regulator that promote the differentiation of erythroid precursors. Erythropoietin play a role in the early stage of erythropoiesis. The other transcription factors like a GATA2 or transforming our TGFB superfamily play a role into the later stage of erythropoiesis. So in normal erythropoiesis, there is positive regulation by erythropoietin, positive regulation by GATA differentiation, and you have your mature red cells. But you have ineffective erythropoiesis as a thalassemia. There is arrest or apoptosis in the later stage due to overactivity of SMAD2/3 signaling pathways. And this is probably in a way with anemia stimulating more erythropoietin production. So there will be a lot higher erythropoietin levels in these patients, leading to expansion of erythroid progenitors and arrest, usually at basophilic erythroblast stage. So the other aspects about JAK2 inhibitors. So in normal erythropoiesis, the physiological levels of erythropoietin induce phosphorylation of JAK2 in normal erythroid progenitor and sustain differentiation of mature red cells. However, in beta thalassemia, as I mentioned, there's a loss control of proliferation with high levels of erythropoietin eventually, and higher number of cells associated with phosphorylated form of JAK2. So trying to block the JAK2, would this produce positive results? It did work fine for certain illnesses like myelofibrosis and polycythemia, reduced the splenomegaly, targeting the same JAK-STAT pathways. So it is tested in patients with thalassemia in phase 2 study, 30 patients with transfusion-dependent thalassemia and splenomegaly. The primary endpoint was change of the red cell transfusion requirement, and the secondary was spleen volume at 30 weeks. There was a reduction in spleen volume over time with ruxolitinib, as expected. Trend for improvement transfused red cells. However, slight improvement in pre-transfusion hemoglobin was not. So result was not really big, or the magnitude benefit would not like that impressive at all. So it was well tolerated, and the limited effect of the drug on this parameter did not advance it for further phase 3 studies. Touch base more about transform growth factor superfamily signaling via SMAD2/3. It's regulate the erythroid maturation during late stage of erythropoiesis. So they act via actinium receptor 2B to trigger the SMAD2/3 signaling pathways, and the binding of ligand triggers phosphorylation of SMAD2/3, enabling it to form heteromix SMAD complex. And the SMAD complex translates into the nucleus, where it modulates the transcription of genes involved in erythroid maturation. So increased aberrant activities of these signaling SMAD2/3 pathways signaling into patients with beta thalassemia is a main component of ineffective erythropoiesis. So here come where the drug was trying, okay, so how can we decrease this SMAD2/3 signaling pathway, where Luspatercept fit in? So it's first-in-class erythroid maturation agent. It's a recombinant fusion protein, consists of modified form of extracellular domain of human actin receptor type B, linked to the Fc domain of a monoglobulin. So it binds to the TGFB superfamily ligands, inhibit actinin 2 receptor activation, decrease the SMAD2/3 signaling, and by decreasing the SMAD2/3 signaling pathway, it enhances the maturation, leading to formation of mature red cells that will be released into the circulation. And the clinical trials looked into Luspatercept from its beginning phase 2 and to major 2-step BELIEF trial. We'll talk about it later. And this is transfusion-dependent thalassemia and beyond. In non-transfusion-dependent thalassemia, we'll touch on it shortly. that showed eventual benefit of this medication. This is just when it's used as phase 2 trial. As you see, patient has a leg ulcer with thalassemia after Luspatercept and increasing their hemoglobin level that allowed rapid healing of the leg ulcer. So the BELIEVE trial, it is a randomized, double-blind, placebo-controlled phase 3 studies, 2-to-1 randomization. Luspatercept as 1 milligram per kg subcutaneous every 21 days versus placebo. And in adult patients, 18 years of age, with a primary endpoint of 33% reduction in transfusion need. So, and this is between that week 13 to 24. So as you see, there is a 20% of patients met the primary endpoint versus 4.5 in the placebo group, with huge clinical and statistical significance. Other subgroup analysis of these cases favoring Luspatercept. So this effect was seen in line of Luspatercept, regardless of kind of age or splenectomy status, gender, or different hemoglobin levels or genotypes, or iron concentration. They look into other secondary endpoints. So between week 37 and up to 48, you still see there's statistical significant with Luspatercept group, 19 versus 3.6. And if you are targeting higher transfusion reduction, like 50%, you still see it with 7.6 versus 1.8 for placebo, which is still statistically significant. And going the same number between not 34 to 24, 37 to 48 weeks, you still the positive effect of Luspatercept, a reduction of transfusion needs. And if you take any 12-week interval or at any 24-week interval, significantly more patients really treated with Luspatercept achieve reduction in red cell transfusion burden of 33 and 50% reduction during any 12-week or any 24 weeks interval. The safety measures, no death cases in Luspatercept versus 1 case on placebo. I mean, talking about the serious, anemia was only serious really treatment emergent adverse events occurring in more than 1% patients in either arm, including the arm of Luspatercept. More than 10% of patients will have some non-specific symptoms like bone pain, arthralgia, back pain, upper respiratory tract infection, and dizziness, and compared to a placebo group. The grade 3 or 4, like in 5% of patients. Treatment discontinuation due to treatment emergent adverse events reported like in 12 and 5.4% Luspatercept patients versus 0.9 placebo patients, but no treatment related death. And if you look about the most common side effects, which is bone pain, arthralgia, and dizziness, you will see that is very minor number of patients had to stop the medication because of these side effects. And if you look at these side effects, which is more common, arthralgia, bone pain, and dizziness, it's more prevalent during initiation of therapy, but it really decreases over time with continuing therapy of Luspatercept. Patients receiving Luspatercept and the BELIEVE trial showed also lower mean cumulative red cell transfusion units and visits through week 48 across levels of baseline transfusion burden, and this is basically as expected. And now the question is about to 24 weeks or extending to 48 weeks. So the benefits of continuing therapy with Luspatercept in patients who did not achieve 33% reduction in transfusion burden in week 13 to 24 weeks still be observed, unlike if they are not on Luspatercept, but the magnitude is not as meeting the primary endpoint. So the quality of life changes during BELIEVE. With the reduction of red cell transfusion burden, the scores, all the quality of life or health-related quality of life scores kind of improving with Luspatercept. I mean, a patient requiring less transfusion, less side effect transfusion, less probably visits to the medical day units, and some of them really off transfusion. So there's no interruption of their life daily. If you look in direct way, the longitudinal effect of luspatercept and iron overload and iron chelation therapy, I mean, it is kind of makes sense. If you are reducing the transfusion, which is the main driving for iron overload and transfusion-dependent thalassemia, you expect all the serum liver ferritin, liver iron concentration, and myocardial iron concentration will be reduced down the road. And this is what's also seen in graphs here, either using parameter of serum ferritin more than 1,000 or more than 2,500, or looking into liver iron concentration or myocardial iron concentration. So luspatercept has been approved by US FDA 2019 and European EMA in 2020, and by Saudi FDA in 2021 to treat anemic patients with beta thalassemia who require transfusion, regular transfusions, and now incorporated into the main guidelines that we are using to manage our patients for those and adults to consider luspatercept 1 milligram subcutaneous every 3 weeks, and titrate maybe up to 1.2 if needed. So this is beyond trial. It is using luspatercept in non-transfusion dependent thalassemia. It phase 2 studies looking to its efficacy and safety. So 145 adult patients with non-transfusion dependent thalassemia. So they require transfusion occasionally. Their hemoglobin like 10 and less, and they use a standard dose of luspatercept 1 milligram subcutaneous every 3 weeks versus placebo, which is both supportive care. The primary endpoint was increasing in hemoglobin concentration by 1 gram in absence of from week 13 to 24, and they looked into other secondary endpoints. So the 145 patients were randomized, 96 received luspatercept, 49 received placebo. The median age around 40, mostly were females. Baseline hemoglobin around median around 8.2. So 77% patient luspatercept achieved primary endpoint, which is 1 gram increase in hemoglobin versus 0% in the placebo. At weeks 13 to 24, 52% in patient luspatercept achieve higher level, which is 1.5 gram or more compared to placebo, and close to 90% patient luspatercept remain transfusion free at week 1 to 24. So there were improvement also in patient-related reported quality of life outcomes, and this is indirectly way by increasing their hemoglobin levels. And the treatment emergent adverse events, like reported in 28.1% of luspatercept group, malignant events only in placebo group, no thrombotic or thrombophlebitis events were reported in either arm. And this is the end of my talk. Thank you very much for listening and paying attention.
Thank you, Dr. Sultan. It was very rich and informative presentation, as it were. We hope, inshallah, this promising therapies could reduce the suffer and the mortality rate between and among thalassemia patients. It's a lot of information, and these slides, it's new for me, if not all the slides. Actually, as you mentioned, the types of thalassemia. My question, Doctor, will there is any factors could affect the good response in treatment, like gender or any mutation that may be related to differ from country to country, from age or any other factors that will play an important role in whether to response successful treatment or not?
So are you talking about the severity of beta thalassemia or transfusion?
No, I mean for the therapies in general.
So, I mean, the therapy is limited in patients with thalassemia. So we have only transfusion or gene therapy, or then we have now, or bone marrow transplant is embedded in pediatric or drugs. So if you talk about each one, there is no, I mean, there is no specific thing that you say it's going to be responding to gene therapy, or this patient might not respond to gene therapy, or this patient might respond to bone marrow transplant or not. I mean, in the studies for bone marrow transplant, for example, the studies all in pediatric, and the cut ages were up the maximum like 17 years old.
Mm-hmm.
The gene therapy, they selected patients who have no sibling, matched sibling, and they offer them the gene therapy. So I don't think there's specific parameters. In general, if you see that is the gene therapy, the non-beta 0 genotype were benefiting the most, other than beta 0 genotype, which is also more prevalent genotype we have in the kingdom. And this is basically in a way that is the milder form mutation. There is maybe some production of normal hemoglobin A, so their hemoglobin a little bit higher, and you might achieve the goal easier. That's my personal opinion. For Luspatercept, I mean, there is no specific, the drugs, it works in all, regardless of your gender, your splenectomized status, as I mentioned in this, and in the graph in general. So that's it.
Do we have exact figures, Doctor, for the prevalence of type of thalassemia in Saudi Arabia?
The prevalence of thalassemia?
Yeah, the type.
No, I'm not aware about such information. I don't know if Dr. Iman aware about that. I don't know.
What is the question again? Sorry.
The prevalence of type of thalassemia in Saudi Arabia. Do we have figures, exact figures? How many?
I think we had this before. I had it in another presentation talking about thalassemia and even the prevalence, how it's variable in different regions of the country, but I can't remember the figures. But I do remember it wasn't, they commented about it's not very accurate as it was started after the premarital screening, and sometimes it's not really picked up early, but unfortunately I can't remember the figures now.
Okay, thank you, Dr. Iman. I think there is no more question from the audience, I guess. Okay, so I think with this we have come to the end of this meeting. It was a very informative presentation and really enlightening tour for all of us. Thank you again for all distinguished speakers and for the audience for being with us.
شكرا عبد الله، يعطيك العافية.
Have a good night.